Today we will be discussing several topics in gastrointestinal pathology. These topics are based on the 7 cases that were reviewed in the case conference. For our first case, the patient was a 71-year-old male that presented with abdominal pain. A stomach biopsy was performed. The diagnosis was marginal zone lymphoma of mucosa-associated lymphoid tissue, also known as MALT lymphoma. Most lymphomas, around 75% of cases, arise in lymph nodes, the spleen, and in bone marrow. Around 25% of cases arise in extranodal sites. The gastrointestinal tract is the most frequent site of extranodal lymphomas, with the stomach accounting for the vast majority, around 85% of such cases. MALT lymphomas are low-grade B-cell lymphomas that are highly associated with Helicobacter pylori infection. Eradication of the offending bacteria is the first-line therapy in early-stage disease. By simply treating the bacterial infection, complete lymphoma remission is achieved in 75% of cases. The overall 5-year survival is as high as 90%. Now for a question. Name one of the 4 associated translocations in MALT lymphoma of the stomach. The 4 translocations that are associated with gastric MALT lymphoma include translocation of chromosomes 11 and 18, translocation of chromosomes 1 and 14, translocation of chromosomes 14 and 18, and finally, translocation of chromosomes 3 and 14. All of these translocations result in activation of the nuclear factor kappa B pathway. Another related question. What translocation in gastric MALT lymphoma is associated with resistance to Helicobacter pylori therapy? The translocation that is associated with resistance to Helicobacter pylori therapy is the one involving chromosomes 11 and 18. This is the API to MLT fusion. Now some more information on MALT lymphoma of the stomach. These are low-grade B-cell lymphomas that are composed of a predominant population of small lymphocytes. This is largely an adult disease with a mean age of 61 years. They may present as severe gastritis or may produce an ulcer or mass lesion. Now consider this question. Are most cases low or high stage at presentation, that is, bone marrow involvement, etc.? Gastric MALT lymphomas are generally low stage at presentation, with the bone marrow typically being negative. The cellular population in MALT lymphoma includes small lymphocytes, monocyte-like cells, and some larger lymphocytes. The principal cell type is the small lymphocyte, which is characterized by slightly irregular nuclear contours, inconspicuous nucleoli, and relatively abundant cytoplasm. These are considered to be centrocyte-like cells. In contrast, the larger cell population is considered to be centroblast-like. These cells typically have conspicuous nucleoli. An important feature of MALT lymphoma is the so-called lymphoepithelial lesion, which refers to infiltration of lymphocytes into epithelial structures and is defined as 3 or more neoplastic lymphocytes causing epithelial damage. This is a highly characteristic finding, but is not specific. Here's an example of MALT lymphoma. Notice the prominent lymphocytic infiltrate that disrupts the glandular architecture of the stomach. The higher magnification view shows the characteristic lymphoepithelial lesion. This next example on the left shows more clearly the lymphoepithelial lesion, which consists of lymphocytes within the glandular epithelium. The lymphocytes have a small round nucleus and a rim of clear cytoplasm. The lesion is confirmed as a B-cell lymphoma with CD20 immunohistochemistry. Most cases are associated with Helicobacter pylori infection, so you often have admixed secondary follicles. These are non-neoplastic follicles that are induced by the bacterial infection. Regarding the genetics of MALT lymphoma, around 25% of cases have the translocation involving chromosomes 11 and 18. This results in the API2 fusion with MALT1. Remember, this is the translocation that results in resistance of the lymphoma to Helicobacter pylori eradication therapy. Gastric MALT lymphomas with the translocation between chromosomes 11 and 18 are generally not associated with Helicobacter pylori infection and therefore do not respond to Helicobacter pylori therapy. What nuclear marker is often expressed in these cases? The answer is BCL10. This protein is known to induce apoptosis and to activate the NF-kappa B pathway. Consider this question. Does MALT lymphoma have a specific immunohistochemical profile? The answer is no. Rather, immunohistochemistry is only useful for documenting a predominant population of B cells and for ruling out other forms of lymphoma. CD20 will help to establish that the lesion is composed of mostly B cells. CD3 and CD43 are also helpful. T cells are CD3 positive and normally express CD43. CD43 expression in B cells is abnormal and is seen in around 40% of gastric MALT lymphomas. To look for aberrant expression of CD43, you need to compare the CD43 result with the CD3 and CD20 markers. Here, in this example, you can clearly see that CD43 and CD3 are highlighting a different population of cells. Although not shown, the pattern of CD43 expression matched that seen with CD20, thus confirming that the B cells were expressing CD43. This is an abnormal finding that further supports the diagnosis of lymphoma. This table summarizes the immunohistochemical profile of MALT lymphoma. They are low-grade B-cell lymphomas that express B-cell markers, including CD20 and CD79A. They often express CD43, which is normally a T-cell antigen. MALT lymphomas are negative for CD5, CD10, and cyclin D1. Now for case 2, the patient is a 72-year-old male that presented for routine colonoscopy. A polyp was identified in the ileocecal region. A polypectomy was performed. The diagnosis was mantle cell lymphoma. Similar to MALT lymphoma, the gastrointestinal tract is the most common extranodal site. These tumors are uncommon and clinically aggressive. They are composed of small to medium-sized lymphocytes. The principal cell type is the centrocyte-like cell. The larger centroblast-like cells are typically absent. Some cases have admixed macrophages, which impart a starry sky-like appearance. As noted, the most common site is the gastrointestinal tract. Consider this question. How does mantle cell lymphoma typically manifest in the gastrointestinal tract? When presenting in the gastrointestinal tract, mantle cell lymphoma typically presents in the form of polyposis. In other words, it manifests as numerous polyps. Mantle cell lymphoma, when it involves the gastrointestinal tract, often produces a diffusely nodular or polypoid appearance, which can be confused clinically with a polyposis syndrome. Always consider the diagnosis of lymphoma when examining a colon polyp that has a dense population of lymphocytes. Mantle cell lymphoma accounts for 3 to 10% of non-Hodgkin's lymphoma cases. They arise in adults with a mean age of 60 years. Males are more often affected by a ratio of 2 to 1. They are most commonly found in lymph nodes, but they can present in the gastrointestinal tract, leading to lymphomatous polyposis. Now for a question. Are most cases low or high stage at presentation? Most patients present at high clinical stage. Peripheral blood involvement is common. Mantle cell lymphoma is an aggressive disease. Most patients are not cured. The median survival is 3 to 5 years. These tumors are relatively aggressive compared to other small B-cell lymphomas. How frequently does mantle cell lymphoma transform into a large cell lymphoma? In other words, do you think the frequency is low or high? The answer would be low. In fact, these tumors generally do not transform into a large cell lymphoma. Now, for an important question, what is the usual immunophenotype for mantle cell lymphoma? You need to know this as a practicing pathologist. Mantle cell lymphoma expresses B-cell markers such as CD20 and CD79A. They may also have aberrant expression of CD43. However, the two markers that are more specific are CD5 and cyclin D1. These tumors are negative for CD10 and CD23. This figure shows a lymphoma that is positive for CD20 and CD5. The tumor cells have a monotonous appearance with irregular angulated nuclei. The diagnosis is confirmed with cyclin D1. To summarize, mantle cell lymphoma expresses B-cell markers such as CD20 and CD79A. These tumors co-express CD5 and cyclin D1. Aberrant expression of CD43 is also found in most cases. Now for a question. What is the characteristic translocation found in mantle cell lymphoma? The characteristic translocation involves chromosomes 11 and 14. This translocation brings the cyclin D1 gene on chromosome 11 under the influence of the promoter for the immunoglobulin heavy chain gene on chromosome 14. This translocation is found in nearly 100% of cases and can be identified using traditional cytogenetics or FISH. The differential diagnosis should include small cell lymphoma, MALT lymphoma, and a diffuse large B-cell lymphoma. The tumor cells in small cell lymphoma have rounded nuclear contours, and they also have the admixed larger cells, which are referred to as centroblast-like cells. Small cell lymphomas are also positive for CD5, but they are negative for cyclin D1. MALT lymphomas have more abundant cytoplasm and have the admixed centroblast-like cells. They are negative for both CD5 and cyclin D1. Diffuse large B-cell lymphomas are high-grade and composed of large pleomorphic cells. This high-grade appearance is not a feature of typical mantle cell lymphomas. However, be aware that mantle cell lymphomas have blastic and pleomorphic variants. Cyclin D1 is very useful in this setting, since diffuse large B-cell lymphoma is negative for this marker. Here are some diagnostic pearls. Always consider mantle cell lymphoma in GI polyps with large lymphoid aggregates. Recognize and report the aggressive blastoid and pleomorphic variants of mantle cell lymphoma. Distinguish these variants from diffuse large B-cell lymphoma using cyclin D1. Remember that diffuse large B-cell lymphoma is potentially curable, while mantle cell lymphoma is not. For case 3, a 57-year-old male is found to have a gastric polyp. The diagnosis was a well-differentiated neuroendocrine tumor. Well-differentiated neuroendocrine tumors of the stomach are also referred to as carcinoid tumors. These are thought to arise from enterochromaffin cells, which are a type of neuroendocrine cell that are normally found in the stomach. They are admixed with the epithelial lining of the stomach and play an important role in the regulation of gastrointestinal secretions and motility. These cells modulate neuronal signaling in the enteric nervous system via the secretion of serotonin and other peptides. Tumors that arise from these cells are generally well differentiated. They are, by definition, greater than 0.5 millimeters in size or involve the submucosa. They account for a small fraction of gastric neoplasms, somewhere around 0.5%. They arise in adults, most commonly in the fundus of the stomach, and appear as polypoid yellow nodules. Carcinoid tumors may show a variety of growth patterns, but nesting and trabecular growth is most common. They may form rosettes, papillary structures, pseudoglandular structures, and may even display solid growth. The background stroma is typically highly vascular and composed of delicate capillaries. The cells are positive for synaptophysin, chromogranin, CD56, and INSM1. Mitotic activity is important in the grading of carcinoid tumors. Additionally, Ki-67 is very useful for measuring proliferative activity and can also be used for grading. Treatment includes endoscopic resection for small lesions or surgical resection for larger invasive lesions. Antrectomy can also be performed. This procedure removes antral G cells, which produce gastrin and drive development of gastric carcinoid tumors. Now for a question. What is the size cutoff for predicting more aggressive behavior in gastric carcinoid tumors? The answer is 2 centimeters. Tumors that are smaller than 2 centimeters and confined to the mucosa or submucosa have a better prognosis, while tumors that are larger than 2 centimeters have a worse prognosis, especially if they are higher grade or have angiolymphatic invasion. Here is a practical point in the reporting of gastric neuroendocrine tumors. If the lesion is well differentiated, then use the CAP protocol for neuroendocrine tumors of stomach. However, if the lesion is poorly differentiated, or in other words, high grade, then use the CAP protocol for carcinomas of the stomach. Also, do not use the term carcinoma unless the tumor is high grade. Grading of well-differentiated neuroendocrine tumors of the stomach has changed in recent years. First of all, we need to clarify an important point. The difference between well-differentiated and poorly differentiated neuroendocrine tumors is largely based on growth pattern. Well-differentiated neuroendocrine tumors have a distinct growth pattern, including nests, cords, and trabeculae, as we previously discussed. In contrast, poorly differentiated neuroendocrine tumors lack any distinct pattern of growth. Rather, they grow in sheets and generally have extensive necrosis. Now we shall consider only the well-differentiated tumors. Grading of well-differentiated neuroendocrine tumors is based on mitotic activity. In the past, the cutoff numbers were based on 10 high-power fields. With this approach, grade 1 is assigned in lesions with less than 2 mitotic figures. per 10 high-power fields. Lesions that have mitotic rates between 2 to 20 per 10 high-power fields are assigned a grade of 2. Finally, lesions with more than 20 mitotic figures per 10 high-power fields are assigned a grade of 3. In the past, neuroendocrine lesions with a mitotic rate beyond 20 were considered to be poorly differentiated. In the present system, as long as the tumor retains a neuroendocrine growth pattern, it should still be classified as well-differentiated. So now it is possible to assign a grade 3 to a well-differentiated tumor. In my experience, this is a rare occurrence. The other change to the system is the introduction of a specific surface area for mitotic counts. In other words, you now need to determine the mitotic rate per 2 square millimeters. Importantly, this needs to be averaged over at least 10 square millimeters. You need to refer to the table in the CAP protocol. You also need to know the field diameter for your 40x objective. Now, for case 4, the patient is a 69-year-old female that presents with gastric pain. She was found to have a small gastric ulcer. The diagnosis was adenocarcinoma. This is the third most common GI malignancy in the United States. That is, the top 3 GI malignancies are colorectal cancer, pancreatic cancer, and gastric cancer. Fortunately, there has been a downward trend in the incidence of gastric cancer in most industrialized nations. Dietary factors play a role. Dried and salted foods increase risk, as does low consumption of fruits and vegetables. Other risk factors include cigarette smoking and Helicobacter pylori infection. There are genetic syndromes that increase risk for gastric cancer. These include hereditary diffuse gastric cancer syndrome, Peutz-Jeghers syndrome, Lynch syndrome, and juvenile polyposis syndrome. Hereditary diffuse gastric cancer syndrome is caused by a mutation in the CDH1 gene on chromosome 16. Peutz-Jeghers syndrome is caused by a mutation in the STK11 gene on chromosome 19. Lynch syndrome is caused by mutations in DNA mismatch repair genes, including MLH1, MSH2, MSH6, and PMS2. Lastly, juvenile polyposis syndrome has 2 associated genes, which are BMPR1A and SMAD4. Now for a question. As mentioned, hereditary diffuse gastric cancer syndrome is caused by a mutation in the CDH1 gene. What protein does this gene encode? The CDH1 gene encodes E-cadherin. Carcinomas of the stomach are most common in older adults, with a mean age of around 68 years. Males are affected most commonly, with a male-to-female ratio of 2. Patients generally present with abdominal pain, anemia, vomiting, and weight loss. The tumors present as large polypoid masses or as a gastric ulcer. Gastric carcinomas may also present in the form of a diffusely thickened gastric wall. From a staging perspective, gastric carcinomas may be viewed as either early or advanced. Consider these 2 questions. What is the definition of early gastric carcinoma? Also, how important is the lymph node status in this definition? Early gastric carcinoma refers to cases in which the tumor is limited to the mucosa or submucosa. Importantly, this classification is irrespective of the lymph node status. On the other hand, advanced gastric carcinoma refers to tumors that invade the muscularis propria and beyond. The take-home point here is that the extent of invasion is much more important than the lymph node status. Survival is much better for early gastric cancer, with an overall 5-year survival in the range of 80 to 90%. Survival is reduced with advanced gastric cancer. For tumors that invade the muscularis propria, survival drops to around 70%. If the tumor extends beyond the muscularis propria and into the subserosa, the 5-year survival drops to 40%. Lastly, if the tumor involves the visceral peritoneal lining, then the survival at 5 years is an abysmal 15%. One additional point, early gastric carcinomas may be amenable to endoscopic resection, while advanced cases generally require more extensive surgery. Grossly, the tumors may be polypoid, fungating, ulcerated, or diffusely infiltrative. Tumors that permeate the entire gastric wall are often referred as linitis plastica. Consider this question: what are the 2 histologic subtypes of gastric adenocarcinoma? Using the Lorne classification system, the tumors may be of the intestinal type or the diffuse type. The intestinal type forms tubular or papillary structures, while the diffuse type is composed of discohesive cells and may have a signet ring cell appearance. The differential diagnosis includes gastric dysplasia, gastric xanthoma, Whipple disease, and metastatic carcinoma. High-grade gastric dysplasia may be hard to distinguish from intramucosal carcinoma. Importantly, in gastric dysplasia, there is no desmoplasia, and the architectural complexity is limited. Xanthomatous cells may mimic signet ring carcinoma on a biopsy. However, the foamy macrophages are confirmed with positive staining for CD68 and negative staining for keratins. In Whipple disease, similar to xanthoma, macrophages are the key element. Bacteria are observed on electron microscopy. Lastly, make sure to exclude a metastatic carcinoma. Metastatic lobular carcinoma from the breast may be particularly tricky. For Case 5, the patient is a 50-year-old male that presented with abdominal pain. An abdominal mass was found. There are no glass slides for this case. This is a PowerPoint-only case. This image shows an abnormal proliferation of cells involving the submucosa of the small bowel. Closer examination reveals irregular nests of epithelioid cells and admixed ganglion cells. The diagnosis is gangliocytic paraganglioma. These are tumors that are composed of an admixture of cells, including endocrine cells, Schwann cells, and ganglion cells. These tumors are uncommon and almost always arise in the ampullary region. They have a triphasic growth pattern with an endocrine component, a spindle cell component, and a ganglion cell component. The three components can all be appreciated in this picture. The endocrine component resembles a carcinoid tumor, which is growing in nests. The spindle cell component, which is barely noticeable at the bottom of this image, resembles a neurofibroma, and therefore is composed of Schwannian cells. Lastly, the ganglion cell component is noticeable towards the middle of the image. The cells have copious cytoplasm, a relatively large nucleus, and a prominent nucleolus. Most cases are sporadic, with a median age between 50 to 55 years. As noted previously, the vast majority arise in the duodenal ampullary region. They may present with abdominal pain, a gastric outlet obstruction, or bleeding. Treatment is excision. These tumors are benign with only rare case reports of aggressive behavior. Typically, these tumors are centered in the submucosa, but may extend into the mucosa. The average size is around 3 to 4 centimeters. They are soft, yellowish, and have infiltrative borders. Histologically, the tumors have a triphasic appearance in variable proportions. This includes spindle cells, that is, Schwannian cells, ganglion cells, and nests of neuroendocrine cells. The tumors are positive for S100 protein, synaptophysin, and chromogranin. Be aware that around 50% of cases may also have positive staining for keratins. The differential diagnosis includes a gastrointestinal stromal tumor, schwannoma, ganglioneuroma, carcinoid tumor, and potentially carcinoma. Now for Case 6. The patient is a 64-year-old male that presents with abdominal pain. He was found to have a 2.6 centimeter gastric mass. The diagnosis was a gastrointestinal stromal tumor. These are c-KIT-positive spindle cell tumors. They are driven by mutations in the KIT or platelet-derived growth factor receptor alpha genes. The most common site for a gastrointestinal stromal tumor is the stomach. About 60 to 70% of cases arise in the stomach, while approximately 20 to 30% arise in the small intestine. Other potential sites may include the esophagus, colon, and rectum. Familial cases may occur with germline mutations in the KIT gene on chromosome 4 or the platelet-derived growth factor receptor alpha gene, which is also on chromosome 4. These mutations are autosomal dominant and typically produce multiple gastrointestinal stromal tumors. Gastrointestinal stromal tumors may also arise in association with neurofibromatosis type 1. This results from the interaction between the KIT gene product and the NF1 gene product. The tumors are c-KIT positive, but they are negative for KIT gene mutations. Gastrointestinal stromal tumors are also found with the Carney triad and Carney-Stratakis syndrome. These are related to alterations of the succinate dehydrogenase complex and are not associated with KIT mutations. Gastrointestinal stromal tumors are relatively uncommon, with around 4,500 new cases per year in the United States. Clinically silent lesions are common. Most lesions remain clinically insignificant and do not progress. These tumors generally arise in adults with a median age of 60 years. Familial examples present around 40 years of age. Cases that present in association with the Carney triad may manifest during childhood. The stomach is the most common site, followed by the small bowel. Treatment includes complete resection and the use of tyrosine kinase inhibitors. Gleevec is a commonly used drug. Newer drugs are available for acquired resistance to Gleevec. Prognostic factors include tumor location, tumor size, and mitotic activity. Consider this question: which is more likely to behave aggressively, a gastrointestinal stromal tumor of the stomach or small bowel? Gastrointestinal stromal tumors that arise in the small bowel are more likely to behave in an aggressive fashion. Around 20 to 25% of gastric cysts are malignant, while 40 to 50% of small intestinal cysts are malignant. These tumors are composed of a uniform population of spindle cells or epithelioid cells which are arranged in lobules. Nuclear pleomorphism is rare. Occasional cases show a dedifferentiated pattern with bland areas and high-grade areas, which are admixed. The tumor cells have eosinophilic cytoplasm and characteristic cytoplasmic vacuoles. The tumors can have a myxoid or myxochondroid background. Skynoid fibers may be present, which are coarse, wire-like bands of collagen that are haphazardly arranged. Poor prognostic factors include extension into the mucosa, as well as tumor necrosis. Name 3 immunohistochemical markers that are commonly used in the diagnosis of a GIST. The answer is c-KIT, CD34, and DOG1. Note that DOG1 is positive in around 50% of c-KIT negative cases. The differential diagnosis should include schwannoma, leiomyoma, leiomyosarcoma, fibromatosis, melanoma, solitary fibrous tumor, clear cell sarcoma, and inflammatory fibroid polyp. All of these entities are generally negative for c-KIT. However, be aware that melanoma can be c-KIT positive. So, for cases that are more pleomorphic, consider evaluating the tumor for melanocytic markers, including S100 protein and SOX10. Here's a summary table that is helpful for risk stratification in gastrointestinal stromal tumors. Remember, tumor site, tumor size, and mitotic rate are the major factors in predicting clinically aggressive behavior. Now for case 7, the patient is a 50-year-old female that presented with abdominal pain. A gastric mass was found. The diagnosis was Glomus tumor of the stomach. These are spindle cell tumors that represent modified smooth muscle cells that recapitulate perivascular glomus body cells. Most examples occur in the skin. These tumors are rare in the GI tract, but when they occur, they are most commonly found in the stomach. The tumors arise in adults with a median age of 50 to 55 years, including a female predominance. They may present with upper GI bleeding. Treatment is complete resection. Most cases have a benign clinical course. There are rare examples with malignant behavior, with no known features that help to predict a potentially aggressive outcome. The tumors are well circumscribed and centered in the wall of the stomach. The median size is around 2.5 centimeters. The tumors have a white to pink cut surface and often display hemorrhage. The tumors often form multiple cellular nodules, separated by bundles of smooth muscle. Intratumoral hemorrhage is common. The overlying mucosa is often ulcerated. The tumors may also display a solid pattern, organized around a prominent vasculature. The tumors may display myxoid change. The tumor cells have ovoid nuclei with clear cytoplasm and well-defined cell membranes. The nuclear chromatin is delicate, and nucleoli are inconspicuous. Mitotic figures are rare. Malignant examples are rare. Aggressive tumors may have a brisk mitotic rate and a more spindled growth pattern. Name 2 positive immunohistochemical markers in Glomus tumor. These tumors are positive for smooth muscle actin and calponin. They are also positive for collagen type 4, which surrounds individual tumor cells. The tumors are negative for desmin and c-KIT. The differential diagnosis should include gastrointestinal stromal tumor, carcinoid tumor, and leiomyoma. The aforementioned stains will exclude the entities in the differential diagnosis. And now, This concludes this discussion of cases in the gastrointestinal pathology series. Thank you.